Well, good morning, everybody, and welcome to Grand Rounds. I'll be introducing Dr. Vince Ma today. I'm Carrie Wazinski, the Chief of Palliative Care. It's my distinct pleasure to introduce Dr. Vincent Ma. As many of you know, Dr. Ma joined the Division of Hematology, Oncology, and Palliative Care in 2021 after he completed his undergrad and medical school training at the University of Nevada, and then followed that by internal medicine residency and Hem-Onc fellowship training at the University of Michigan. Since joining the division, Dr. Ma quickly became a trusted expert in the management of skin cancers. He's emerged as a leader of clinical research, and especially those focused on immunotherapies. He's been the PI of a number of early phase and skin cancer trials and has become a leader in accruing clinical trials across our center. Recognizing him as an emerging leader, he has been asked to take on some faculty leadership in our clinical research office, including positions as the immuno-oncology program lead in the early phase oncology therapeutics team and the non-melanoma advanced cutaneous malignancies program. One of Dr. Ma's most recent accomplishments was that he led a multidisciplinary team to bring Hepzato, melphalan percutaneous hepatic perfusion therapy to UW Health. And this is for the treatment of metastatic melanoma. And this made UW one of the first 6 cancer centers in the US to have this treatment available after FDA approval. And as many of you know, that's a ton of work to do that type of new program here at University of Wisconsin. He was awarded the Golden Bucky Award for this work. Dr. Ma is also a KL2 scholar, where he's investigating novel biomarkers for the treatment of melanoma. And that ties in incredibly well with his presentation today, which I'm excited to hear, which is optimizing advanced melanoma management with emerging biomarkers. Welcome, Vince.
Thank you so much, Dr. Wazinski, for the really lovely introduction. And first of all, I'd like to say good morning to all the attendees that are here virtually. And I also want to say thank you to the Department of Medicine for inviting me to give today's grand rounds. And so, as Dr. Wazinski mentioned, I'm very honored and pleased to be able to talk about, a disease that I'm just so quite passionate about, and to talk a little bit about some of the exciting research that we've been doing here at the University of Wisconsin. So these are my conflicts of interest disclosures. And then these are today's learning objectives. So one is to describe the challenges of the current state of biomarker development in advanced stage melanoma. The second is to compare the differences between prognostic versus predictive biomarkers in cancer. And then finally, to actually describe the mechanism of liver metastases that contribute to diminished immunotherapy efficacy. So, as a medical oncologist who primarily specializes in melanoma and skin cancer, you all must be sort of wondering, why does melanoma matter, right? Well, the important thing about melanoma is that while it is one of the skin cancers that exists, it actually accounts for about 1% of all of these cases, particularly here in the United States. But unfortunately, is the leading cause of most of the skin cancer related deaths each year. In terms of how often we see this, melanoma is considered to be the 5th most common cancer in both men and women in the United States. And unfortunately, more than 20 people die from this disease each day. And so when we oftentimes talk about melanoma, we often think about it as cutaneous melanoma. One of the things that's, is a pretty shocking sort of statistic that we've been learning, say, over the last several years and several decades is that despite our best efforts to campaign the use of sunscreen, protection of sun exposure, we're starting to and continuing to see an increasing incidence of melanoma diagnoses in the United States, despite a relative stability in terms of non-cutaneous melanoma diagnoses. So it's a pretty shocking and scary thing to see, but very likely we all may at some point be seeing these types of cases in the future. And so, to talk a little bit about melanoma and typically what I see in my practice, here in the state of Wisconsin, we see a a pretty good number of farmers, those who are pretty much outside quite often and get a lot of sun exposure. So there are actually a lot of cases of cutaneous melanoma in the state of Wisconsin, but primarily in my practice, what I often see are patients who are diagnosed with more the advanced stages of the disease. Typically these are the stage 4 disease where the disease has unfortunately spread to other regions of the body, oftentimes viscerally, like to places like the lungs, the bones, the liver, and even the brain. And oftentimes, when I see these patients for an initial consultation in clinic, I oftentimes like to give a little bit of a history about how we used to treat this disease, this advanced or metastatic or stage 4 melanoma. And so, oftentimes, when I tell patients, if you were to see me back in the early 2000s, at that time, we really didn't have much in terms of systemic treatment options. The median overall survival with the best available therapy at that time, which was chemotherapy, was a very dismal 6.4 months. And then, really, now, as we flash forward into what we have nowadays, we have a variety of different FDA approved systemic therapy options. Really, since 2011, we have the first availability of the modern day immunotherapy treatments, also known as immune checkpoint inhibitors. And since 2011, we now have approval of a variety of different systemic treatment options, including other immune checkpoint inhibitors. We also have targeted therapy that can also target BRAF mutations that are commonly seen in melanoma. And then a major landmark this past year where we have the FDA approval of lifileucel, which is cellular therapy, the first in its kind approved to treat a solid tumor. And so with this sort of success, what we can kind of see nowadays is that what was thought of to be almost an impossible feat to do nearly a decade and a half ago, we can see these patients with advanced stage melanoma who can actually achieve wonderful remissions and people living longer than ever before. And I think a lot of us can really attribute much of that success to immune checkpoint inhibitors. And so to really highlight one of the immune checkpoint inhibitor regimens that was been studied, for the past decade or so, is looking at the role of dual agent immune checkpoint inhibitors, specifically ipilimumab plus nivolumab. Published this year was the Checkmate 067 trial, which was a prospective study that looked at the overall efficacy of using dual immunotherapy treatment. And if you compare that to what we saw nearly a decade, 2 decades ago, we can honestly see that the melanoma-specific survival for patients who were treated with combination or dual agent ipilimumab plus nivolumab is greater than 10 years, which is a pretty amazing thing to honestly say nowadays with how we have really come so far to effectively treat this disease. Now, when we really talk about immune checkpoint inhibitors, this is a relatively, new type of treatment. I know that when I was even back in medical school, we didn't really learn too much about what immune checkpoints were and certainly not what immune checkpoint inhibitors were. And so to just kind of give a very brief highlight, so, immune checkpoints are really these proteins and these receptors that are part of the normal immune system. And really their role is to help prevent the immune system from being so strong that it really targets our own healthy cells in the body. And so when these immune checkpoints engage, in the proteins on the surface of your immune cells, amongst each other, but also your tumor cells, it sort of gives a signal to the T cells. These are these white blood cells that are responsible for your immune surveillance and clearing cancer from the body, but it sends a signal to them to be off. And so when that sort of engagement occurs, that is something that sort of permits sort of a tumor escape environment. And so scientists over the years have kind of studied that we can sort of take advantage of this and develop these antibodies that can sort of disrupt these interactions, these checkpoints that occur. And so we have these agents like anti-CTLA-4, anti-PD-L1, anti-PD-1. And by introducing these antibodies, you can sort of block the interaction between these immune checkpoints to allow for activation of these T cells, sort of lifting the brakes off the immune system so that it can promote an elimination of tumor cells in the body. So a pretty amazing breakthrough that we've had over the past decade and a half. Since FDA approval of immune checkpoint inhibitors, particularly in melanoma, melanoma has really been the disease that has pioneered the use of modern day immunotherapy, immune checkpoint inhibitors. And really, since then, we've had an evolution in terms of optimization, particularly of this therapy. But now, what are we seeing? Immune checkpoint inhibitors are now being approved and utilized across multiple different cancers that exist, including colon cancer, gastric cancer, head and neck cancer, lung cancer. In fact, really, since the introduction of immune checkpoint inhibitors, all these cancers have really begun to follow suit. And so the lessons that we learn, particularly about optimizing immunotherapy, particularly for melanoma, is something that could one day be applied to other cancers as well. So with the success, particularly with the modern day immunotherapy treatments and a variety of the treatments I mentioned, previously we had seen an increase in terms of melanoma deaths prior to the introduction of these therapies. But really since 2013, I think it's pretty amazing to see that the mortality has finally started to decrease for this disease. And there's certainly a lot of pros and cons when we typically think about some of the treatments that I mentioned. Patients are nowadays living much longer than ever before. We're seeing a decrease in mortality. And to be honest, this is not something that we would honestly think about, but could we potentially be curing some of these patients with stage 4 cancer? We see that the durability, the long-lasting effects of immunotherapy, that some patients may actually no longer have active cancer in their body when effectively treated with some drugs like immunotherapy. The main issue at this point is that nearly half of the patients, unfortunately, don't respond to immunotherapy. And some of the patients who do get treated with it, unfortunately, can get pretty significant side effects. So, how is immunotherapy or immune checkpoint inhibitors typically given in clinical practice? And so, it is an intravenous type of treatment. It's typically given once every 3 to 4 weeks, depending on the regimen that's being given. And usually, when we give these drugs to patients, we oftentimes go through an instruction about, the expectations, in particular about what to anticipate in terms of treatment response as well as side effects. But in terms of the standard, in terms of how we monitor how patients will do with treatment, we typically will obtain scans about 3 months after starting treatment to actually see if treatment is working. And the reason for that is, right, for 3 months, we hope that we're using that immune system as an intermediary to really help promote and grow and essentially to help promote the anti-tumor effect, which is why we sort of have to wait that long. And so, as you can sort of imagine, the amount of anxiety that sort of comes with it, right? The amount of just worry about not knowing if I'm going to be responding to treatment during that entire 3 month period. And it certainly as a provider, I can sort of empathize with patients as well, and knowing that there's a great deal of worry about how they are doing throughout the course of treatment. And in addition to that, not only are we thinking about the anti-cancer efficacy, we also have to think about the balance of also managing the immune-related adverse events. So these are side effects that occur from immune checkpoint inhibitors because as you lift the brakes off the immune system with the hope that they're attacking the cancer, one of the adverse events is that your immune system can also attack other parts of your normal healthy tissue. And what I often instruct to patients in clinic is that our immune system is present everywhere from our head to our toes. And so, in theory, almost any organ of our body can actually be affected by the immune system when introduced with immune checkpoint inhibitors. These are just some examples of some of the side effects that we see. So to the far left, we see a patient there with inflammatory dermatitis. In the top middle there is a presentation of immune-mediated colitis. Top right is a example of immune-mediated digital vasculitis. And in the bottom there is immune-mediated pneumonitis. So some of the scary side effects that can certainly develop as a result of being treated with these therapies. So when it comes to treating patients with these particular types of therapies, we oftentimes have to think about, well, are there any ways that we can sort of think about knowing and understanding how a patient's going to do, in terms of these treatments? Is there some sort of crystal ball that allows us, especially for both patients as well as providers, to better understand how well a patient's going to do. And that's really where biomarkers sort of come into play. And so, really, what I wanted to illustrate here with this particular slide is that there's a ton of different biomarkers right now being studied, particularly for metastatic melanoma. And by no means is this list here intended to be comprehensive. But the whole intent that I want to show here is that there's a variety of different biomarkers being explored, whether they're tissue-based biomarkers, imaging-based biomarkers, blood-based biomarkers, a variety of them that are being studied by both clinical investigators as well as scientists over the last several years. And the important thing to kind of mention here is that some of these biomarkers may be done, to assess and actually predict whether patients are going to do well with treatment. Some of them can be done as pre-treatment, on treatment, and then there's certainly differences in terms of prognostic versus predictive biomarkers. And as I mentioned, many more of them are still undergoing investigation. So, a relatively important topic that I really want to discuss is really just kind of understanding the two main types of biomarkers that we typically use in cancer. And sometimes the terminology can sort of be misinterpreted between one another. And so, the two ones that I really want to discuss are the differences between prognostic and predictive biomarker. And so a prognostic biomarker really refers to a particular marker that actually helps inform a likely cancer outcome that is sort of independent of the treatment that's being rendered. So a really good example would be, say, a patient with metastatic cancer who has brain metastases. I think many of us would agree that having cancer in the brain is really a really poor sort of prognostic sort of marker. That regardless of what sort of treatments that are obviously rendered to these patients, that they're likely to have a really poor outcome, a poor survival outcome. Contrast that to a predictive biomarker that is essentially a marker where if the treatment effect is really different from having that marker compared to a patient that does not have that marker. And so it's really more of a marker that relates to the actual treatment effect. So an example for that would be a metastatic melanoma patient who has a BRAF mutation, which occurs in about half the patient population. By having that mutation and being able to give that treatment, we can actually see an anti-tumor effect. Whereas giving a BRAF inhibitor, we would not see that anti-tumor response. So these are relatively important factors to certainly talk about and sort of thinking about how we can one day think about converting or thinking about prognostic into predictive biomarkers, which I'll have an opportunity to talk a little about today. So I'm kind of pleased to be able to kind of talk about some of the exciting research, it's particularly in some of the biomarkers that we're doing here at the University of Wisconsin. And one particular area of research that we've been exploring is actually looking at the role of nuclear imaging as a biomarker for cancer research. I think many of us who are in clinical practice, one of the most common nuclear imagings that we use is the role of the FDG PET scan. What's really quite nice about these FDG PET scan, and particularly the tracer that we use, is that we sort of get an opportunity to do a comprehensive assessment of the patient with these imaging. So not only are we able to look at the lesions and the size and the volume, but we can actually look at the metabolic uptake. And what's really quite advantageous, particularly for patients with cancer, is that we can use some of that information to tell, is a patient responding to treatment? Are they developing resistance to treatment? And certainly a growing and evolving area is actually using that tracer, that FDG PET scan, to actually assess the risk of developing a toxicity as well. One of our colleagues here, Dr. Steve Cho, who is also a collaborator in some of our projects here at UW, had actually done some of this research at Johns Hopkins, where he actually conducted a study with some of his colleagues where they actually looked at the role of the FDG PET scan at about 1 month after starting immune checkpoint inhibitor. And really, the hope was that the assessment at 1 month after being treated with immunotherapy can actually predict or actually be indicative of future best response to melanoma treatment with ICI therapy. Now, specifically in the cohort they analyzed, they looked at patients who were treated with ICI monotherapy. And using a variety of different criterias in particular, they looked at both morphologic as well as metabolic parameters. And what they found was they sort of designed this particular response criteria. And with relatively high sensitivity and high specificity and high accuracy, we can actually use that PET imaging at 1 month that can be indicative of how well patients are likely to respond to treatment. So really challenging the idea that imaging doesn't need to be delayed until 3 months to assess a response to treatment. So what we have done here at UW is really develop sort of a part two, sort of the next level in terms of assessment. And so currently we actually have a prospective pilot study that we have opened here at the institution, trying to look at the value of that early interval PET scan at around 3 to 4 weeks, concurrently with circulating tumor DNA, which I'll talk about a little bit later, in patients with advanced stage melanoma who are treated with immunotherapy. This pilot study in particular has been funded by the UW General Research Pilot Award, and it really involves a great collaboration between our nuclear medicine team as well as our medical physics team. And so the hope here is that we really want to look at the value of this PET scan, not with monotherapy, but with doublet immune checkpoint inhibitors. And so this is some of the data that we presented previously at AACR, but we'll also be publishing or presenting some of these updated works next week at the Society of Immunotherapy for Cancer. But what I really want to hopefully illustrate here is that sort of the dynamic change, the changes in terms of the largest lesions that we see in the cancer, as well as the changes in the metabolic update, between the baseline and at the 3 to 4 week mark can actually be very much indicative in terms of how well patients are going to do in terms of progression-free survival. So it's very exciting to kind of see this as a very cool and novel biomarker that we could potentially use one day as a means to help inform patients, but also providers on how well they're doing with treatment early on in their treatment course. Another sort of area of exploration that we've also been looking into as well is using the PET scan to actually quantify the amount of metabolic uptake in some of the organs that are commonly affected by immune checkpoint inhibitors. And so published, over the last several years is that we can quantify those uptake. And specifically in the bowel, we've seen that some of the uptake that occurs in the bowel can actually precede the actual onset of symptoms related to colitis. And we're starting to continue to explore that sort of ability and capacity to do that assessment in other disease organs that can also be affected as well. Another collaboration that we've also been doing with some of the PET imaging is actually working with a biotech company here in Madison called AIQ Solution, but also partnering with colleagues at the Mass General Hospital is actually utilizing artificial intelligence to actually develop models to help better inform our ability to know how patients are responding to doublet immune checkpoint inhibitors for patients who have metastatic melanoma. And this is a particular trial that's been open for the last several years, funded by the NIH SBIR grants. So what is some pretty interesting things that we're doing with artificial intelligence is, we can now do sort of a comprehensive assessment, sort of develop a response map, a toxicity map, using a computer AI algorithm by assessing numerous patients and assessing how well patients respond to treatment over a long period of time, and using that sort of information to help computerize it and automate sort of that entire process. And what's really quite amazing about sort of using this type of technology is that, oftentimes with immune checkpoint inhibitors, we get sort of this heterogeneous response. And so by using sort of all the comprehensive assessments, we can sort of develop sort of a way to holistically assess how well patients will do with therapy and really do a number of unique calculations to do that. And so this is an area of evolvement that we're sort of developing. And so how can we sort of develop sort of an AI generated report to give you that comprehensive assessment? So for example, looking at this report here to the left, we can look at areas in the body that, for example, are growing or increasing in size, but we notice that there's some areas that are also decreasing. But holistically, we can sort of assess how patients are going to respond by developing sort of that AI sort of algorithm and calculation. In the future, we sort of hope that with some of this new technology with early interval PET imaging, we can develop an algorithm that can actually give a patient and provider a score that can actually inform us how well a patient is likely to do. So pretty exciting stuff, to say the least, in terms of where this is sort of going. And the role of AI is certainly entering the field, particularly for melanoma as well as imaging. And as of right now, some of the analyses and publications will certainly be forthcoming as a result of this particular trial. So kind of switching gears a little bit, I also want to take an opportunity to talk a little bit about some blood-based biomarkers that we're also doing some research on here at the University of Wisconsin. So what are some of the advantages, some of the pros, particularly associated with blood-based biomarkers? Well, the nice thing about blood-based research is that, blood samples are readily accessible. And the nice thing is that we can repeat the tests quite easily. We have the capabilities of repeating the test serially and even longitudinally over time, and actually have an opportunity to assess the dynamics in terms of how well patients are responding to treatment. Blood-based research is potentially cost-effective. It's certainly a lot cheaper to some extent than some of the FDG imaging, PET imaging that we can use. And really the nice thing about blood-based biomarkers is that we have an opportunity to actually detect microscopic cancer within the blood. Certainly, some of the disadvantages associated with it is that patients have to unfortunately undergo needle pokes. And of course, there's the component of actually drawing blood from the patients as well. One particular area that I've been focusing on over the last several years is actually looking at the value and particularly the role of circulating tumor DNA for patients. And so this has been sort of a major and evolving role over the last several years. And so, nowadays, circulating tumor DNA has really become a test that has become increasingly more available and has now become commercially available as an opportunity to help almost any patients with any particular cancer, to help providers and patients know, for example, the assessment of the cancer's DNA that the patients have been previously diagnosed with, and allow us to monitor that over a course of period of time. And so how does the commercially available circulating tumor DNA test sort of work? Well, in particular, one that has been available sort of over the last several years is a test called tumor-informed circulating tumor DNA. And so how this sort of works is we actually go back to the patient's tumor tissue, and you actually assess and look for any of the DNA changes that are associated with the tumor itself. And you sort of develop a personalized, customized design assay that is specific for the patient and specifically their cancer. And that particular test is something that we can monitor serially over time as we collect patients' blood samples. Now, because it takes time to sort of customize the patient's first blood test, it actually takes about 3 to 4 weeks for that first result to come back. But as we collect this blood test serially over time, the results and the turnaround for these tests to come back usually is anywhere from 7 to 10 days. And what's really nice about this particular commercially available test is that we can actually quantify the amount of circulating tumor DNA at any particular period of time. This has been an area that's been sort of explored now in multiple different disease types, including colon cancer, breast cancer, lung cancer, bladder cancer, and ovarian cancer, with a variety of different publications that have emerged over the last several years. So where is the application, that we can have, particularly for circulating tumor DNA? Well, one in particular is, we can use this particular test to assess response to treatment before surgery, and is an opportunity for us to actually detect minimal residual disease. Can we detect disease following definitive surgery and removal of a cancer? We can use it as a means to detect recurrence over time, following surgery. But for me, one of the areas that I've been mostly and primarily interested in is looking at the value and the role of circulating tumor DNA as a means for treatment response monitoring. And so the below figures here sort of illustrate sort of a report that would commonly be presented for a patient who have ctDNA monitoring during the course of treatment. The bottom left represents a patient who had a detectable ctDNA level, and as you can see, that level begins to rise and seems to correlate with disease progression. Whereas on the bottom right represents a patient who had a detectable amount of circulating tumor DNA that has essentially been cleared over the course of treatment. So ctDNA monitoring during the course of immunotherapy for particularly advanced stage melanoma has been explored and investigated by a variety of investigators. One in particular that's been published and presented by a group at Moffitt looked at the role of ctDNA dynamics, particularly the change in terms of the ctDNA level at 6 to 8 weeks after the start of immune checkpoint inhibitors. And what they found was that patients who had certainly a decrease in terms of ctDNA had a much better progression-free survival compared to patients who had a ctDNA increase. So again, really challenging the idea that we can actually assess the overall benefits of immunotherapy much earlier than the 3-month follow-up interval. Well, the one thing that I really want to explore further and sort of seems to correlate quite well with what we've been seeing with terms of PET imaging at the 3 to 4 week interval is maybe we should be thinking about assessing ctDNA dynamics much earlier in the treatment course. Rather than the 6 to 8 weeks that has been previously explored, maybe we should be looking at the 3 to 4 week interval. Can we begin to see the anti-tumor effect much, much earlier on? And so the coalition and the efforts that we're doing right now is I am currently leading a multi-institutional effort where we have great collaborations with investigators throughout the entire country to actually help validate the use of ctDNA monitoring during the course of immunotherapy for patients with advanced stage melanoma. And so what have we done so far? We've collected over 100 patients with advanced stage melanoma, some data where we can actually assess, for example, the ctDNA dynamics and the change longitudinally during the course of immunotherapy treatments. And what we discovered was looking at the 3 to 4 week interval, we can see that patients who have a ctDNA increase had a much worse progression-free survival and overall survival compared to patients who had an overall ctDNA decrease at the 3 to 4 week follow-up after starting immune checkpoint inhibitors. In fact, what was also pretty amazing is that amongst those patients who had a ctDNA decrease at the 3 to 4 weeks, we assessed those patients even further and found that those patients who had an ultimate clearance of ctDNA had a much, much better progression-free survival and overall survival than those who maintain ctDNA positivity over the course of treatment. So a really great effort that our team has really been doing over the last several years, and we hope to publish some of this data relatively soon. As I sort of mentioned and highlighted, many of the biomarkers are currently under investigation, and there's certainly a lot of pros and cons associated with it. And I think what's really important as we think about using some of these biomarkers, particularly in practice, is we really need to think about some of these prospective validation studies and certainly working with other colleagues throughout the country and different cancer centers. Now, in terms of the future direction, particularly with these biomarkers, I kind of mentioned at this point, that we can assess, for example, how well patients are doing well with treatment at the 3 to 4 week interval. But why does it matter, right? Does it really matter that we know how well patients are doing at the 3 to 4 week mark? Well, one could potentially make the argument that knowing the prognostic outcome with these particular biomarkers, these dynamic changes, maybe we can actually intervene upon them at the 3 to 4 week interval. Maybe we can actually develop what we call a response adapted treatment strategy so that we can actually improve the outcomes of patients treated with immune checkpoint inhibitors. Maybe we can actually make patients who, unfortunately, the half of those patients who don't benefit from immunotherapy, how can we get those patients to do much better in the long run? And so the challenge right now, particularly for melanoma, is that we have a variety of different treatment options available. And there's this concept that certainly exists where maybe more drugs leads to better outcomes. But the challenge associated with that is that as we give more drug, we're also dealing with more side effects. And we know that some patients can benefit from treatments that are not as intense, but there are some patients who, for example, need more therapy than others in order to benefit or respond to immunotherapy. And there's a very wonderful quote made by one of the medical oncologists at Yale, Dr. Harriet Kluger, and she made a very important point, particularly when we talk about melanoma, but also for other cancers as well, is that we really need to improve patient selection to administer less aggressive regimens when possible. And what we certainly need is better predictive biomarkers. And so what I have certainly in proposal right now for a variety of different studies that are in development is how do we sort of use sort of that response adaptive strategy? And so the concept certainly exists where if you have a patient with advanced stage melanoma, the common practice is you give doublet immune checkpoint inhibitor therapy. If we can do, for example, a 3 to 4 week ctDNA assessment, we can assess for those patients who are likely to have a ctDNA decrease, they're bound to do very well. So we continue with the standard treatment regimen. But for those patients who are bound to eventually do poorly, this is an opportunity where we can intervene and not wait until that 3 month mark, where we can then add an additional drug to help optimize their outcomes. And we can continually to assess the dynamic change over the course of treatment. And as we see how well the patients are responding based on their ctDNA levels, we can maintain their treatment or escalate their therapy even further so that by the time we get to the 3 month interval, we have an opportunity to optimize the outcomes of those patients who initially would be doomed to do poorly. So with that, I'm also excited to kind of talk about another interesting biomarker that I've been very passionate and have been working on quite a bit over the last several years. And in particular, it's melanoma liver metastases. And so liver metastases was something that we sort of discovered as a really interesting biomarker for patients treated with immunotherapy when we sort of analyzed a relatively large cohort of patients when I was back at Michigan on over 300 patients with advanced stage melanoma treated with immune checkpoint inhibitors. And what we did was we looked at a variety of different locations that patients had disease. And, we had initially thought that patients who had brain metastases were likely to do poorly with immune checkpoint inhibitors. But what we sort of discovered was that, very interestingly enough, that patients with liver metastases actually had a very poor overall survival outcome. In fact, almost as bad as brain metastases, if not slightly worse. And so that kind of raised a lot of questions, certainly as well. And certainly at our institution, we also looked at over 250 patients with advanced stage melanoma. And we also saw that similar pattern. Patients with liver metastases seems to have one of the worst overall survival outcomes. And when we correlate that with some of the prospective studies that have also existed, I mentioned earlier the Checkmate 067 trial, which was a study that led to the landmark approval of combination ipilimumab plus nivolumab. But what we saw is that patients without liver metastases had a much better overall survival outcome than those patients with liver metastases. And so that sort of raises a lot of interesting thoughts because, well, is it really in the setting of immune checkpoint inhibitors, or can it be applied to other sort of treatment settings as well? And so is liver metastases potentially prognostic versus predictive? And so one way we can sort of answer that is we looked at patients who, for example, were treated with targeted therapy. And so targeted therapy not being immune checkpoint inhibitors, but we looked at patients who had a BRAF mutations and those who were treated with a BRAF inhibitor. And we found that when we compared the differences in terms of progression-free survival between those who had liver mets and those without, there was really not much in terms of progression-free survival differences. But specifically with immune checkpoint inhibitors, there was a clear difference in terms of PFS. Now, of course, you might be wondering, well, liver mets, might potentially be a marker for other factors as well. It could be indicative of lots of disease burden. And so what we also did was we conducted a multivariable analysis where we accounted for a variety of different characteristics and confounding factors that might impact a patient's overall progression-free survival and overall survival outcome that might confound the ability for us to understand liver mets. And after doing and conducting a multivariable analysis, we can still see that liver metastases continues to prognosticate a poor outcome for patients with liver mets. So it is a relevant finding for us to see that. And what we are noticing in particular is that this particular pattern is something that we're also recognizing across multiple different cancer types as well. It is not necessarily just applicable to melanoma. As we've seen over the years and after what we published, we're starting to recognize that liver mets, particularly in lung cancer, urothelial cancer, kidney cancer, colon cancer, that the presence of liver mets will actually indicate a poor outcome with immune checkpoint inhibitors. So the lessons we learn in particular for melanoma are starting and continuing to be applicable to other disease types as well. Now, scientifically speaking, why is it? Why does it seem to be sort of this case? And so what we've sort of learned is that potentially liver metastases may actually restrain immunotherapy efficacy. And so the colleagues that have been able to work with, some of the scientists that we worked at Michigan, we were able to kind of better understand sort of the preclinical understanding behind all this. And so what we did was we really looked at mirroring models. And in particular, we looked at mice who were inoculated with tumor in the subcutaneous region. And we also looked at mice who were just inoculated with tumor both in the subcutaneous and in the liver as well. And what we did was we did liver biopsies of the normal liver parenchyma. And interestingly enough, what we really wanted to look at was sort of the immune microenvironment of the liver itself. And what we noticed was that there were actual differences between mice who had just disease outside of the liver versus those who had disease both in the liver as well as outside of it. In particular, what we noticed was that there was a significant decrease in terms of T cells and an increase in terms of macrophages in mice that had liver metastases. And in particular, what we noticed is that there was an increase in terms of apoptotic signatures, particularly in activated CD8 positive T cells. So a very, very interesting finding that we noticed, particularly in the mirroring models. And so what our proposal is that in terms of the mechanism, is when we think about sort of the normal immunotherapy administration sort of pathway, when you give immune checkpoint inhibitors, you sort of prime these T cells in our body, and they sort of need to traffic and get to the tumor and get infiltrated there to provide that anti-tumor effect. But sort of along the route there, one of the stops that it needs to make is certainly through the liver. And in the absence of cancer or metastases in the liver, there's really no sort of a diminishment of these T cells. So then you sort of get that anti-tumor control that you would want when treated with immunotherapy. But in the presence of liver metastases in the far right figure, we can see that as the T cells need to get or migrate to the tumor themselves, the presence of liver metastases sort of promotes an immune microenvironment that increases macrophages that ultimately leads to increased T cell apoptosis. And ultimately, as a result of that, diminishes these T cells from getting to where the tumor needs. And as a result of that, promotes tumor growth. There's less tumor control overall. As we sort of explore this, we kind of understand that, especially when we biopsy the peripheral tumor, we notice that in mice who do not have a tumor in their liver, that they have an increase in terms of CD8 positive T cells, which then subsequently lead to less tumor volume. But in the presence of liver mets, the CD8 positive T cell is certainly diminished compared to mice that do not have liver mets. And so what we really understand in this particular case is that liver metastases may actually lead to a systemic immune desert. And really the interesting mechanism behind that is macrophages can actually mediate T cell elimination, leading to fewer activated CD8 positive T cell infiltration in the periphery. And overall, we suspect that liver mets may actually diminish anti-tumor activity with immune checkpoint inhibitors. But how can we sort of help overcome this is, well, there's been ongoing studies now looking at how can we sort of remodel the hepatic immune microenvironment. In that same publication that we did, we also looked at the role of introducing liver-directed radiation therapies. And so treating one or two of the liver metastases, we might be able to decrease the macrophages and actually decrease T cell apoptosis so that those T cells can get to where they need to at the tumor and provide that more effective tumor control. Having explored this, particularly in the mirroring models, what we discovered is that when you look at the combined modality of both a PD-1 inhibitor, which is an immune checkpoint inhibitor, with radiation, that we can actually increase the amount of CD8 positive T cells in the periphery than with either modality approach alone. And so interesting enough, we can see that great correlation between CD8 positive T cell infiltration alongside with the tumor volume reduction. So following sort of that publication, what we had also done and what I was able to contribute was a pilot study where we looked at the role of liver-directed radiation plus immune checkpoint inhibitor, specifically dual immune checkpoint inhibitor. And this was a pilot study that we actually had opened several years ago at the University of Michigan, where we wanted to look at patients who had advanced stage melanoma with liver involvement and to see what is the outcome of these patients when treated with these dual modality approach. Now, unfortunately, due to COVID, this particular study unfortunately had to be closed. But that doesn't really end right there because there are still some ongoing questions that still remain. How can we think about better remodeling the liver immune microenvironment? Does it really make sense to only treat the macroscopic disease? Because one of the main limitations with radiation is that we can only treat and select number of macroscopic disease. Maybe we need to think about treating the entire liver, including the micrometastases that also exist as well. And is there a particular cancer model type, that we can really help draw experience from to more effectively treat patients with metastatic cutaneous melanoma? And that particular model to really learn a great deal from is in particular metastatic uveal or ocular melanoma. This is a relatively rare subtype of melanoma. It only occurs in about 2,000 newly diagnosed cases each year here in the United States. And what we know is that with this uveal or ocular melanoma, it is associated with a worse prognosis than metastatic cutaneous melanoma. And what's very unique in particular about this particular disease is that a very common location that this disease likes to go to is the liver. About 90 to 95% of the time, we'll see this disease spread to the liver itself. And there's very limited effective treatment options to actually treat this disease. And so the lessons we learn for treating this disease, particularly with immunotherapy, could hopefully help us better understand treating cutaneous melanoma, but other disease types that have liver involvement as well. So what do we know, particularly when we treat metastatic uveal melanoma with combination immunotherapy? The response rate, meaning the threshold to have an appreciable reduction in tumor size, is pretty darn low. The progression-free survival and the median overall survival associated with treating these patients with doublet immunotherapy is also quite dismal compared to skin melanoma. And so one of the ways we can sort of think about treating the overall liver is actually introducing and using this new novel therapy that is effective and has been FDA approved to actually treat metastatic uveal melanoma that's in the liver. And that is the melphalan percutaneous hepatic perfusion therapy, also known as Hepzato. And so the way this technique works is that you actually have to have patients in the OR. And what we do is we actually isolate the venous blood flow to the liver. And what we do by that is we try to help minimize the effect of the chemotherapy, which we would administer by using a catheter that goes through the femoral artery that goes all the way to the hepatic artery. And we administer high doses of chemotherapy, specifically melphalan, a dose that we would not otherwise be able to give intravenously through the vein. And by doing that, we can actually saturate the entire liver itself, being able to destroy, hopefully, the macroscopic, but also the microscopic disease that's present in the liver. And because you've isolated the venous blood flow, very minimal amounts of it actually enters systemically. Following this, we actually filter out the actual chemotherapy itself. So after about 30 minutes, we hopefully remove as much of the chemotherapy so that very minimal amounts of it actually enters systemically. So the idea behind this melphalan percutaneous hepatic perfusion therapy is that we can actually minimize the effects of this chemotherapy that enters the rest of the body. What led to the approval of melphalan PHP was the FOCUS trial, which was a phase 3 study that was conducted here in the United States. The treatment was considered to be relatively safe. The main side effect was the hematologic cytopenias that exist with this therapy. But what we saw was that the response rate was certainly much higher than what we really have available for the treatment of metastatic ocular melanoma, a response rate of about 36.3% and a disease control rate of about 73.6%. And so, since the availability and FDA approval of melphalan PHP, we've been able to introduce this particular therapy to the University of Wisconsin. And since March of 2024, we've treated a total of 15 patients and more than 60 procedures at our institution. And what's pretty fantastic is that we've seen a lot of great success, a great number of patients who have responded quite well to this therapy. In fact, this is an illustration of a patient who had a very markedly large tumor from metastatic uveal melanoma. And after just one cycle, one particular treatment of Hepzato, we can see nearly a 50% reduction in terms of the tumor. And that seems to correlate quite well with the circulating tumor DNA response. Something that we'll be planning to publish in the very near future is just the real world efficacy of using melphalan PHP, particularly within our institution. And what we've been seeing so far is that the response rate data seems to be better than what we've been seeing historically with some of the prospective data. And so we plan to publish sort of the technique that we've been using. And I have to give kudos to sort of our interventional and interventional radiology team and anesthesiology team for sort of helping to kind of grow this program altogether. So bringing this back to kind of what we were talking about a little bit ago is how can we think about optimizing or really improving the outcomes of patients, particularly with disease that affects the liver? Well, presented about 2 weeks ago was at the European Society of Medical Oncology there was a phase 2 study looking at the role of combining hepatic perfusion therapy with combination immune checkpoint inhibitors in patients with metastatic ocular melanoma. And this was their study design. They looked at 76 patients who were randomized, half of them to receive melphalan PHP, and the other half of the patients to receive both PHP plus doublet immunotherapy. And what they discovered was that those patients who had a combined immunotherapy plus melphalan PHP result had a significantly higher objective response rate compared to patients who had just PHP alone. In fact, with a response rate of about 76.3%, is considered to be one of the highest response rates we've seen for any particular therapy that's been used for this particular disease so far. And we also had some great results that we saw in terms of the progression-free survival and overall survival when treated with the combined modality approach. And so with this sort of finding that we can see so far, our hope, particularly here, is that we hopefully can extract this and really bring this further into metastatic cutaneous melanoma. And I'm really excited to say is that we now have an investigator-initiated trial proposal that we are hoping to open relatively soon, which is a phase 1b/2 trial looking at the safety, tolerability, and efficacy of combining melphalan PHP plus a doublet immunotherapy in patients with metastatic melanoma with liver metastases. And the emphasis that we want to have here is predominantly patients that are non-ocular melanoma. And so in terms of the trial schema that we plan to enroll, our initial goal is to enroll our first 15 patients to assess the safety as well as the tolerability. But we'll be conducting a variety of different correlative studies that will be done throughout the entire treatment course. Similar to the Chopin study, we'll actually be incorporating two melphalan PHPs sort of sandwiched in between the immune checkpoint inhibitor regimens. Inclusion criteria will include patients that have non-uveal melanoma. So the emphasis here is cutaneous melanoma, and they must have biopsy-confirmed liver metastases, good performance status overall in order to participate. And of course, as we try to better understand not only the clinical aspect behind it, we also want to know the preclinical, the mechanism behind all this as well. So we'll be incorporating a variety of correlatives that will go alongside with this. So we'll be conducting liver biopsies and peripheral blood biomarkers, some of the ones that I had mentioned previously, so that we can actually assess sort of the mechanism about why this particular combined modality approach is working effectively. And so overall, the study is poised to hopefully be activated within the next month or so, but we're hoping to be able to enroll our first patient by Q4 of this year. And so with that, I would like to say thank you to a variety of folks who have worked with me over the last several years, including my primary mentors, Dr. Albertini, Dr. Lang, a variety of our research collaborators, our colleagues and supporters, the students I've worked with, the trainees I've worked with, and a variety of external collaborators that I've also worked with over the last several years here at UW to really make our biomarker program here at UW flourish. And certainly can't just forget about the patients who have also been willing to participate in some of the studies that I mentioned as well. And so with that, I also want to say happy Halloween, but I'm also happy to take some questions as well. Thank you.
Vince, I have not seen that Bucky picture before, so oh, well, excellent presentation, and I congratulate you for all of your work and I mean to the field as well. Like I remember the days when metastatic melanoma was an incredibly poor prognosis, and it's really amazing to see the progress. And excited to see where it goes in the future. So I will see if there are any other questions and people can put them in the Q&A, but I did have a question a little bit based on this idea of like or adaptive therapy based on early response. And, as I think about that, we've tried this in a lot of different fields of oncology. And to me, always the key tenets are one, can we be confident enough in the test to completely de-escalate or stop therapy early? And then two, do we have other effective therapies if something's not working to adapt to that will be successful? So what are your thoughts? Do you think that this is really a path forward for melanoma?
Yeah, I think definitely. I think we can think about, a disease type in particular where we can sort of draw a lot of experience from. So, like lymphoma, for example, we know that for their disease, it has become sort of standard of care that, after giving a pretty cytotoxic chemotherapy regimen, you get a scan, and if they are doing well with treatment, we can actually de-escalate therapy and that they can actually still have just as good of an outcome as those who continue with the aggressive regimen. And I absolutely think that is definitely the pathway in the future, not just for melanoma, but certainly for a lot of different cancers as well. I think a lot of us, particularly in the space of thinking about developing better outcomes in terms of therapies for patient, that has been sort of the approach that many of us are sort of thinking about is using some of these biomarkers to help inform us about when is the right time to really intervene and help optimize outcomes. Albeit, the challenge right now is that we still need to continue to work on developing better therapies. And so as we think about using these biomarkers to change treatment, we still need to continue to work on better optimizing some of the therapies that we have currently in place. But I absolutely agree, not just melanoma, but I think this can apply to multiple different disease types as well.
I will agree. And then just recently, I'm hearing a little bit about the idea of immunoprevention. Like, could we potentially prevent melanoma or other cancers that are kind of very immune based? What are your thoughts? I know this crowd in particular is a lot of primary care and hospital medicine. Like, can we prevent this?
Yeah, that's a really great question and something that can be something that, many of us can actually look forward to, not only just in the oncology world, but also in the primary care setting, is that something that's been really evolving is the idea of using vaccine therapy, and, in melanoma in particular, there was a phase 3 study that just recently completed and we're just waiting for the results of, but actually looking at the role of an mRNA vaccine to actually help prevent a pre-existing cancer that was previously diagnosed to actually prevent that cancer from coming back. And what we've seen, at least in the early phases of the study, like phase 1 and 2, is there's been some efficacy that we may actually prevent that same cancer that existed from returning. And so where I really see, particularly in the future, especially for a lot of cancers that are very sensitive to immunotherapy, and as I mentioned, I think melanoma has really been pioneering sort of our understanding about immunologically hot tumors, is that what we learn from melanoma can one day be stratified to other disease types. And so hopefully by 2027 is when we anticipate to get a readout of that phase 3 study. But honestly, the whole idea behind vaccine therapy is something that, has been a challenge in terms of research over the last several years, but we're getting a lot better at it. And we're excited to see that it might be something we may see not only on the oncology side, but it's also in the primary care setting as well.
I'll agree. And I'll put in plug for a study that I have coming soon too, looking at a vaccine and early stage breast cancer also to prevent recurrence. So I think it is a field that's finally really merging. So, all right. Well, thank you to everybody. We're at time and appreciate your expertise, Dr. Ma.
Thank you so much.